Og da vil jeg bare ønske velkommen til ME-foreningens webinar i dag. Vi har med oss Peter Rowe, og han skal introdusere seg selv litt senere. Først skal jeg bare fortelle litt om hva som kommer til å skje. Vi skal først vise en video med et foredrag med Peter Rowe som vi har tatt opp tidligere, og så vil det være mulighet for å stille spørsmål underveis. Then I'll just say welcome to Peter, and you can introduce yourself. I think you have so many titles, it's hard for me to remember all of it.
Well, thank you, Trudy. It's a pleasure to join you all again this morning. I am Peter Rowe. I was educated in Canada at the University of Toronto and then McMaster Medical School. I did my training in pediatrics at Johns Hopkins, and since the mid-1990s have been running the chronic fatigue clinic at the Johns Hopkins Children's Center, and my clinical focus has been on patients who have different types of fatiguing illnesses, mainly ME-CFS. And so today we'll be talking about the intersection of ME-CFS and joint hypermobility and conditions like Ehlers-Danlos Syndrome. Well, thank you, Trudy. It's a pleasure to join you in Norway again. And today I'll be talking about the issues posed by joint hypermobility or Ehlers-Danlos Syndrome in those with ME-CFS. This has been an interest of ours for a couple of decades now. I don't have any relationships to disclose, and we'll discuss some commercial products. This is the intersection that we've been interested in, that those with joint hypermobility, which is joints that can move beyond the standard range of motion, and some of those patients will have Ehlers-Danlos Syndrome. That group has a lot of orthostatic intolerance, and we know that's a key feature, one of the core features of ME-CFS. So I want to explore this intersection today with you. And the way we'll go about it is I want to provide a little bit of background on Ehlers-Danlos Syndrome and joint hypermobility, look at how the association with ME-CFS came to light, then look at some of the common conditions that are associated with Ehlers-Danlos Syndrome, because I think recognizing these can help improve the clinical care of those with ME-CFS. And then Trudy asked me to add on, because of its topicality, a few words on long COVID at the end. So Ehlers-Danlos Syndrome is a heterogeneous disorder of connective tissues. And for those who are not medical, the connective tissues are things like skin, ligaments, tendons. They're present in the eyes, the arteries, the veins, bones, heart valves. Really, they're what keeps us connected and together. They're distinct from the organs that do the work, but they provide some of the structure of those organs. And there are a number of genetic mutations in the different types of Ehlers-Danlos Syndrome, and that's why it's referred to as a heterogeneous disorder. But most of them are characterized by varying degrees of skin hyperextensibility or stretchiness. These were the rubber men at the old circus sideshows. Joint hypermobility and cutaneous or skin fragility. And most of them result from mutations in the genes that encode the fibrillar collagens or enzymes that modify collagen. And because fibrillar collagen provides the strength and structure to essentially all tissues and organs, Ehlers-Danlos Syndrome has really widespread clinical manifestations. Among the things that we used to read about in the monographs were early onset of varicose veins, easy bruising. And then in most monographs, you would read out of 70 pages that easy fatigability and widespread pain were common. And this was presented initially as if it was an unavoidable feature of the syndrome and that there was nothing to be done about it. And that's changed dramatically in the last 25 years. We measure joint hypermobility using this fairly simple, rapidly employed score invented by Peter Byton, and it's called the Byton score. You get a point on either side for the ability to bend the fifth finger back more than 90 degrees. You get a point for bringing the thumb up to the forearm. You get a point for more than 10 degrees of hyperextension of each elbow and each knee. And the 9th point is for forward flexion of the trunk with the knees straight and the palms flat on the floor. So the maximum score is 9. The Beighton score doesn't measure how stiff one is, so that it's really only 1/2 of the normal range. There are some issues with the Beighton score, and one can have EDS without having a score of 4 or 5 or higher, but usually a score of 4 to 5 is considered consistent with hypermobility. One of the interesting features, and this provides an overlap with the epidemiology of ME-CFS, which affects women more than men, is that in all countries where this has been looked at in children, we see that females are much more likely to have hypermobility, regardless of how the study defined it, than males are. So this can range up to as high as 41% of females aged 12 in Iceland versus 13% of the males. And that preponderance of affected women versus men in the hypermobile type of Ehlers-Danlos syndrome is presently unexplained. Having said that, it's important to recognize that hypermobility itself is not a disease. This is a trait that's present from birth, and it endows those who are hypermobile with the ability to excel in certain sports, such as dancing, swimming, gymnastics, and other activities where stretchiness and the ability to have an increased range of motion are advantages. Not all of those patients have symptoms. We got interested in this when we were surprised by a diagnosis of Ehlers-Danlos syndrome in a patient of ours who had a Beighton score of just 1, but the geneticist felt that she was really quite abnormal. So we looked carefully at the next 100 adolescents that came into our chronic fatigue syndrome clinic at Johns Hopkins over a 1-year period. And out of that 100, 12 were identified with Ehlers-Danlos syndrome, which is much, much higher than one would expect by chance using population figures. And 6 of them had the classical type of Ehlers-Danlos syndrome, 6 had the hypermobile type, 11 were female, and all 12 of the ones that we found also had chronic orthostatic symptoms and some objective abnormality on either a tilt test or a standing test. So they either had neurally mediated hypotension, which we discussed in an earlier webinar, POTS, or both. And all of them, when they were placed upright in a standing test or a tilt test, had an increase in their orthostatic symptoms. The median Beighton score in this group was 7. They had 12 of them had prior joint dislocations, 3 had even had surgery. They all had this peculiar purple discoloration of the dependent limbs called acrocyanosis that we see in patients with orthostatic intolerance. They didn't have a lot of stretchiness of the skin, except, as you can see in the top picture, increased extensibility of the upper eyelid. Some of them had these widened, thinned out scars, and the girl on the right at the bottom had had a laparoscopic appendectomy, which usually should give you about a 1 centimeter small scar, but hers had dehisced. It came apart, so the surgeons had to sew it up again, and it came apart again within a week, and they sewed it up, this time with a plastic surgeon to help with the wound healing. But the surgeon and the general surgeon and the plastic surgeon were beginning to suspect that the mother and the daughter were pulling the sutures out early, a kind of Munchausen by proxy or Munchausen syndrome. But the problem was that they hadn't done a general examination of this girl, who had a Beighton score of 8 out of 9, and she had EDS. And in EDS, the skin pulls away from the suture line, and the sutures need to be left in about twice as long as usual, and usually reinforced a bit. So this was a bit of an unfair accusation. We then asked, well, if we're seeing more chronic fatigue syndrome and orthostatic intolerance in those who have Ehlers-Danlos syndrome, what about children who have chronic fatigue syndrome, do they have a higher prevalence of non-syndromic joint hypermobility? Are they just much more stretchy? So we looked at Beighton scores in 58 new and 58 established patients and 58 healthy controls. And the median Beighton score in the group with ME-CFS was 4 versus 1 in the healthy individuals. And we saw a much higher proportion of our patients being hypermobile. So among a group with ME-CFS, 60% met criteria for hypermobility versus just 24% of the healthy children. And this was the distribution of their Beighton scores. And you can see in the yellow that the healthy people, 24% had a score of 4 or higher. So this was like you'd see in just about any other population of patients in high schools, where they were probably the dancers and gymnasts and cheerleaders. Notice, though, in the blue, the distribution of Beighton scores in the ME-CFS patients was much, much different. It's as if these were two completely different populations. So one of the things that's intriguing about this is a biological risk factor for ME-CFS. It doesn't mean that everybody who's hypermobile is at a high risk for ME-CFS, nor does it mean that everybody with ME-CFS has hypermobility, but it's a biological risk factor, and it's present from birth. So we know that the typical age of onset of ME-CFS is in adolescence. So we wondered then if having hypermobility would mean that you were likely to get ME-CFS early at a younger age, and perhaps less likely to have it triggered by an infection. We also thought that because of the associated joint pain that patients often have, that they might have more severity in their ME-CFS defining symptoms, more comorbid conditions, and that their activity and health-related quality of life would be less. So we took a cohort of 55 of our patients. Actually, before we get to that, I'll just show you some of the other things that these patients can do. So here's some slides showing the tricks that patients can do with their hands. The girl in the middle at the top has rotated her knee around about 180 degrees. She can put her leg behind her head. At the bottom left is the prayer sign, the girl putting her hands together behind her back. The next one to the right of her shows the ability to touch the tongue to the tip of the nose. That's called a Gorlin sign. And then patients with EDS who have stretchy upper lids can also invert the lids quite easily. They also have stretch marks fairly commonly, even without a lot of weight loss. They can have these widened, thin scars like you see on the bottom left. And then there's a feature that you look for on the examination shown on the bottom right called Piezogenic Papules, or pressure papules, where you get subcutaneous tissues coming out through the surface of the skin. These are not painful, but they are part of the definition for the hypermobile form of EDS. So proposed mechanisms for the association of joint hypermobility and orthostatic intolerance. The one that we proposed when we first described this back in 1999 was that because you've got the same connective tissues in your skin and ligaments as you have in the wall of your blood vessels, that allows some stretch of the blood vessels. And when one is standing and there's an increase in pressure within the venous system, that causes more dilation of those vessels, leading to excessive pooling of blood in the lower half of the body, less blood coming back to the heart, and less going to the brain, and thus you get the orthostatic intolerance symptoms. There is some subsequent support for the concept that the vessels are stretchier. Others have suggested, I think quite strangely, that physical inactivity as a result of joint dislocations and pain may be disabling due to associated anxiety, depression, and a somatosensory amplification state. This may lead to secondary hypersympathetic responses triggered by fear of pain on standing. I just have never seen this in our population. They're not fearful of standing. They're aware of their symptoms, and many are not at the point that this author suggests of being completely inactive. So I think this is a hypothesis that's easily dismissed. Others have thought there might be a peripheral neuropathy. There is evidence that excessive mobility of the cervical spinal cord due to loose ligaments at the skull base and in the neck can lead to dynamic compression of the nerves and the spinal cord, and thus to autonomic symptoms. And there's been some new work by the American surgeon Fraser Henderson showing that many patients with EDS have, or some patients with EDS have problems with either craniocervical or atlantoaxial instability, and those patients have improvements in their lightheadedness and syncope after surgical fusion. We know also that mast cell activation syndrome is more common in those with joint hypermobility, so maybe that's another factor that contributes to the orthostatic intolerance and thus to the ME-CFS. Or perhaps there's another shared factor that goes along with the joint hypermobility. And as I mentioned a little bit earlier, we were interested in how patients with hypermobility and ME-CFS present. So we had a cohort of 55, and that was divided into two groups. 27 had no evidence of joint hypermobility, as defined as a Beighton score of 0 to 3, and 28% had a Beighton score of 4 or higher. This was the joint hypermobility positive group. And much to our surprise, and against all of our study hypotheses, we found no significant differences in the age at onset of their ME-CFS, the type of onset. We had hypothesized that those with joint hypermobility would have a kind of gradual onset. They didn't need it to be triggered by an infection. We thought their ME-CFS symptoms would be worse, that they'd have more orthostatic intolerance and comorbid conditions, and that their health-related quality of life would be worse. And in fact, there was no significant difference between the groups. Now, this was a fairly small study, so it may not tell the entire story, but it suggests that in addition to joint hypermobility being a risk for ME-CFS, you must need some other factor to be present as well. As it's often termed in medicine, perhaps this requires a two-hit phenomenon. Well, that might not be the end of the story, because my collaborators, Linda van Kampen and Frans Visser in Amsterdam, have a gigantic database of patients who have been studied with tilt table testing and measurements of cerebral blood flow. And they put together a case control study where they looked at their hypermobile patients, and they really were quite strict. Patients had to have been defined as hypermobile by a geneticist or a rheumatologist or some other specialist, or they had to have a Beighton score of 6 or higher. So this is a really hypermobile group. And then they picked out 100 matched controls, age and sex matched controls from their database of ME-CFS patients. And they looked at the difference in brain blood flow. And here you can see that the patients who were hypermobile had a 32% reduction in brain blood flow when they were upright on the tilt table test for 30 minutes versus 23% in the non-hypermobile patients. Now that compares to the healthy control data, which were only a 7% reduction. So clearly the non-hypermobile ME-CFS patients were still very abnormal. But the difference between the hypermobile and the non-hypermobile patients in their much larger study was quite significant. So I think we'll need to continue to look at this issue and also continue to look at why, at least in younger patients who who don't have this kind of duration of illness of about 10 or 12 years, may be closer to one another. Others have followed the work that we first published, including some very elegant work by Inge de Wandelay in Belgium. She did autonomic symptom scores in those with EDS, and on the right is the EDS patients versus controls. And the autonomic symptoms included orthostatic intolerance and fainting, but also sweating abnormalities, problems with gastrointestinal motility and movement like constipation, as well as bladder and pupillary changes. And you can see that there's a very significant difference between the EDS hypermobile type patients and the controls. On the left, she mapped out the differences between the hypermobile patients and those with classical Ehlers-Danlos syndrome. And there was more of a merging, although clearly the hypermobile patients had more autonomic problems. A word on how EDS is usually labeled. There had been a variety of attempts to classify the illness, usually by experts who met in different cities. So the Berlin nosology suggested there was a type 1, which was the classical type, and type 3, which was the hypermobile type, and type 4, which was the vascular type. They then met about 10 years later in Villefranche and came up with these labels: classical, hypermobile, vascular, and others that are very easy to detect because the patients have a lot of unusual spinal problems or unusual skin or facial appearances that would not lead to anyone to suspect that they're entirely healthy. Then in 2017, led by a Belgian geneticist, Francisca Malfait, there was a decision made because there were so many genetic causes that had been identified that they were going to classify each form of EDS based on the molecular conformation with causative variants in the respective genes. So the next slide is not meant to be easily readable, but it just lists the various genes and mutations and the proteins that those genes code for. And you can see that there are at least 13 types of EDS. Unfortunately, the most common of these in the population, the hypermobile form, number 5, has no known genetic basis. So we still have a difficult time separating those who have joint hypermobility alone from those who have hypermobile EDS. One of the things that separates the hypermobile from the classical forms are skin findings being more severe in the classical form. So on the left column of this picture, you see the widened so-called papyraceous scars. They look like cigarette paper in the old days. And then on the right, you see real changes with masses under the skin, pseudotumors, and subcutaneous spheroids like in panel F. But these are not only just seen in classical Ehlers-Danlos syndrome, but they appear later in life in those patients. And as a way of illustrating that, here we've got 3 generations from the Baltimore area where they all had classical Ehlers-Danlos syndrome, and the girl on the far left is an adolescent who has very few, if any, changes in the knees and shins. In the middle is her mother, who has this hemosiderin, a red cell byproduct, deposition in the kneecaps and along her shins, and then her father has had varicose vein stripping as well as knee surgery, and he's got more of the hemosiderin deposition on the shins as well. So you may not see all of these features in the children and adolescents. This is another close-up of the kind of stretched out scar that is often seen in EDS. One other reason to look for Ehlers-Danlos syndrome is that the type 4 in the old days, or the vascular EDS, can have an unusual facial appearance with hollowed cheeks, a very thin nose, no earlobe, often protruding eyes, and thin lips. Unfortunately, it's not always this characteristic, and this is a textbook kind of appearance. The patients with vascular forms of EDS are important to identify because they're at risk for arterial and hollow organ rupture. So this can be a much more lethal form of the disease. Where diagnosing joint hypermobility in patients with ME-CFS comes in very handy both for the patient and the physician is the knowledge that many non-joint disorders are associated with joint hypermobility. So there's a higher incidence of anxiety. You can see things like carpal tunnel syndrome, neuroanatomic problems like Chiari Malformation and as I mentioned before, cervical spine instability. Many patients can have chronic pain. There's been a recognition over the last 10 years that in gastrointestinal specialty clinics looking at motility disorders in the intestinal tract, that patients with hypermobility are overrepresented. They often can have constipation, fecal incontinence, sometimes rectal prolapse. You can get headaches because of spinal fluid leaks because the dura are made of the same stretchy, fragile connective tissue, and those patients will present with headaches that are worse when they're upright. People with joint hypermobility can have hiatal hernias. They can have mitral valve prolapse that contributes to palpitations. Pelvic congestion syndrome, I'll show you a slide of that in a minute. As women age, they can have pelvic organ prolapse. We've talked about the orthostatic intolerance. They can have spinal problems like scoliosis and kyphosis, temporomandibular joint dysfunction, and a variety of pelvic pain problems. This is a slide showing an injection, and I hope you can see my cursor, but here's a catheter going up through the right groin and passing over into the left renal vein and then coming down into the ovarian vein and injecting contrast. Normally you'd see one single ovarian vein, and I think you don't need to be a radiologist to see multiple tangled vessels in through here with clusters of wormy looking vessels. The contrast goes across the uterus, and the normal venous valves that ought to stop the contrast from getting to the right side are incompetent, so there is more contrast, again filling varicose and multiple collateral veins on this side. This was a medical student who presented with problems with fainting and fatigue, and actually was doing so poorly that she had to redo her first year in medical school. But she also had prolonged low back pain and pelvic pain with prolonged standing, and she came to see me because she was worried that when she was on her clinical rotations she would have too many symptoms and not be able to work with the surgeons. And we recognized that pattern of pain with prolonged upright posture fit with these varicosities. The veins get stretched out and it's really quite uncomfortable. Women who have this have not only the low back pain and pelvic pain, but they have quite a lot of discomfort with things like tampon insertion and intercourse. So in the distant past, in the 1940s, they were said to be emotionally frigid, but they were avoiding sex because it was such a lacerating experience. It has become evident since the 1980s that you can insert through the catheter these coils and chemicals to plug up the dilated and varicose ovarian veins, and within about a month they scar down and are no longer stretched and painful. Here's the contrast in the ureter on the post study, and this leads to a dramatic improvement in people's pelvic pain, and also we found in their ability to remain upright. So that's an important comorbidity to be aware of in the joint hypermobility Ehlers-Danlos Syndrome population. It's usually, ovarian varices are usually more common in women who've had 2, 3, 4 pregnancies or more because the veins get stretched out during pregnancy, but we've seen it in adolescents as well. If you look at quality of life scores in Ehlers-Danlos syndrome, they look very much like the same questionnaire results in those with ME-CFS. And I think it's important that in order to properly characterize ME-CFS quality of life, that we separate people into the ones who do and don't have hypermobility. A large study looked at psychological distress in those with what they termed benign joint hypermobility syndrome. And the odds ratio for having anxiety, the odds ratio was quite high, and we're not quite sure if the anxiety is secondary to the orthostatic intolerance or to some other factor. But this is not an attempt to blame patients, but just to recognize that this might be another factor that requires treatment. Similarly, when people look at those with temporomandibular or jaw discomfort and pain, the vast majority of these patients have hypermobility. So it's the ligaments around the temporomandibular joint that lead to trouble and can cause a lot of pain in the jaw as well as headaches. I mentioned the association with Chiari Malformation, again slightly higher in those with hereditary disorders of connective tissue, and the same goes for the cranioscervical instability. On the left is a picture of a normal MRI of the brain showing the cerebellum here and the cerebellar tonsils. They do not descend through the foramen magnum, which is at this line. On the right is a young woman I started seeing when she was a teenager, and you can see that the odontoid bone, the second cervical vertebrae, is positioned in a retroverted way that narrows the foramen magnum, the hole through which the spinal cord has to come. The cerebellar tonsils have very little spinal fluid around them. They're wedged and triangulated down. The brainstem is bent forward. This looks quite abnormal. And not only is this area narrowed, but it's so narrowed that spinal fluid cannot get out of the ventricles, and she's got hydrocephalus. So she needed decompression surgery and a shunt. Here's an example of the kind of presentation you can see in those with Ehlers-Danlos Syndrome and joint hypermobility. This girl liked to play volleyball, and she had the first of many shoulder dislocations when she was 10. And then at age 18, she started having multiple episodes of fainting without any prodromal warning. So she wouldn't get any lightheadedness or sense that she was unwell. She just went down like a stone. She had marked fatigue and met the criteria for ME-CFS, and she had sustained 19 concussions by the time I saw her. She was on a number of treatments that are appropriate for syncope, but they had done nothing. And we recognized from the quality of the scar at the site of her shoulder surgery that it was thinned out, like in the slides I've shown you. She had stretch marks on the medial thigh, even though she had not had big weight changes. She had those small Piezogenic Papules of the heel when she was standing. Her Beighton score was elevated. She had the blue sclera that often go along with Ehlers-Danlos syndrome. The sclera are the whites of the eyes. And she had a very abnormal neurologic examination with brisk reflexes at the knees, and you could elicit those same reflexes tapping her thigh 5 centimeters above the kneecap. So we obtained an MRI, and this is this young woman after sustaining one of her concussions without and a black eye without any warning. And on the MRI, which she's seated here, you can see the odontoid has some pannus or excessive tissue formation behind it that not only narrow the spinal cord, but abut the spinal cord itself. And when she bends her neck forward, that area gets more direct contact and strain. So this allowed us to go back and really revisit her history. What are you doing when you faint without warning? And she said, well, usually I'm splashing water in my face, bending over at the sink. And that was enough pressure on the spinal cord to cause an immediate loss of consciousness, and her face would hit the porcelain of the sink or the toilet next to it and knock her out. She improved when we put her in a hard cervical collar, but the collar was inconvenient. She would take it off every so often and also then get another fainting episode. So ultimately, she had a fusion of C1 to C2 to stop her from doing that bending and to avoid the kind of recurrent concussions that might have led to chronic traumatic encephalopathy. And she's now been 4 years of free of syncope, is married, doing very well as a health counselor. I've mentioned a number of things that can give people trouble when they have hypermobility and EDS in the setting of ME-CFS. But I don't want to leave you with the impression that everybody does poorly over time. Here's an example of a 16-year-old whose hypermobility helped her be a very good dancer and swimmer. She got lightheaded as she started into puberty. her heart rate went from 78 supine to 125 standing, and her blood pressure at that point fell at the 7-minute point 20 millimeters of mercury, and she was pre-syncopal just after 7 minutes. So she was very symptomatic. She had a very high Beighton score, and she had a number of the features I've mentioned to you. Her overall wellness score when we saw her initially was 40 out of 100, where somewhere above 85 is what most healthy people endorse. 100 is as good as you could imagine feeling. So she had quite a degree of ME-CFS impairment. But with physical therapy directed at her joint hypermobility, and it has to be a very special kind of physical therapy that doesn't focus so much on exercise therapy, but more on manual treatment to improve the strength and stability of the joints, strength of the muscles around the joints and their stability. We started her on extra salt and fluids, medications directed at her orthostatic intolerance, and she had a gradual improvement, and after 2 years she was able to resume dancing, go on a 6-mile hike, and she joined the Reserve Officer Training Program, a sort of pre-Army training group for adolescents and young adults, and she was able to perform 72 sit-ups in 2 minutes, 38 push-ups in 2 minutes, and to do a 2-mile run. And by 2.5 years in, she was off all medications and was approved for military service. And I think you can see from the expression on her face that she's doing very well. So it is not an automatic consignment to disability when you have these diagnoses, but knowing what the person has helps us tailor the treatments and make sure they're getting the appropriate form of physical therapy, the appropriate medications for their other problems. I don't know how many of the NATO forces in the Ukraine are going to be wearing fingernail polish, but we're hoping they don't have to get their nails dirty. Okay, let's move on a bit to discuss, as Trudy requested, something about long COVID. We published a paper in April of last year just to show that if patients had a fair impairment of function after COVID, that by 6 months they all met the criteria for ME-CFS. We had 2 females and 1 male. They were 19, 22, and 30 years of age. All of them had been working or studying and were doing so full-time before they got sick with COVID. And they all met the IOM criteria, Institute of Medicine in the US criteria for ME-CFS, by 6 months, and certainly continued to at 12 to 15 months. Let me focus on the 19-year-old. He was a student at the Johns Hopkins University. He had a past history of a mild elevation in bilirubin called Gilbert's syndrome, but he had significant allergies to pollens and grasses that led to allergy immunotherapy from ages 10 to 13. He still gets oral allergy itching and swelling if he's exposed to carrots or cashews or cherries, so he still has a lot of allergic inflammation. And he had mild but well-controlled asthma that was well enough controlled, in fact, that he could run 60 to 70 miles per week as part of his cross-country team training before he got sick. In June of 2020, living in Florida with his parents, where there were very high rates of the Delta variant of COVID, he developed a mild upper respiratory illness with cough, sore throat, some headache, and flu-like symptoms, and his PCR testing was positive. He had some change in his sense of smell for several months, but he was never sick enough to be hospitalized. 2 or so weeks after the onset of the illness, as he would have after any other cold, he tried running, but this brought on coughing, a lot of labored breathing, and a lot of lightheadedness, and provoked some post-exertional malaise, notably with worse fatigue and lightheadedness. And he started paying more attention, as runners do, to his heart rate, and he noted that his heart rate was elevated walking between rooms of the house, again only about 2 weeks in. In August, he played a game of cornhole, as it's called in the southern United States, essentially a beanbag toss, so not very much activity. With this, his heart rate went up to 170 beats per minute for 30 minutes, and it provoked 3 days of exhaustion and post-exertional malaise. His cardiologist looked for any kind of problem with the heart and lungs, but all of the studies were negative. We saw him in September, about 4 months out, and he had an examination notable for mild elevation in his Beighton score of 3. He had a very abnormal neurologic examination, and he had some focal areas of tightness on his physical therapy screening tests. His laboratory studies were not normal. He had an elevation in his histamine, which reflected his allergic or mast cell activation symptoms. But the most amazing thing was his heart rate elevation. He went from a resting heart rate of 59 over 10 minutes to a heart rate of 129. So he more than doubled his heart rate simply standing still. Sorry, this was a 3-month after onset. We tried him on a number of treatments that we use for postural tachycardia syndrome, like Florinef, atenolol, midodrine, pyridostigmine, and ivabradine, none of which were effective for him. But he did get some benefit from clonidine at night, even though we know from a Norwegian trial that that's not universally effective in ME-CFS. Every now and then it can help people with their sleep. He got a mild benefit with his cognition with methylphenidate, and he had a big increase in his sensory stimulation. He was overwhelmed by the noises that you get in a shopping mall or when there's a large crowd, and that improved with a tiny dose of escitalopram. At 12 months, he was able to take his online university courses, and he tolerated a summer internship where he worked from home for 40 hours a week. By 1 year after the onset of COVID, his main symptoms still were fatigue, unrefreshing sleep, and PEM. The lightheadedness and headaches were fairly infrequent on the treatments we were giving him, and he'd long since recovered his sense of taste and smell. But he was only able to walk 15 minutes twice a day with his parents, and his heart rate would still reach 130 beats per minute. So we knew that advancing his activity more than that would simply bring on another PEM flare. He was being treated with famotidine and fexofenadine, which have antihistamine properties directed at the high histamine level. And as we do for many patients with ME-CFS, we tried him on low-dose naltrexone, which seemed to help. We saw him for the 18-month follow-up, and for this past semester in the fall, he was able to take in-person courses. He began some manual physical therapy to address the movement restrictions and the tightness in his legs. And then after doing so, was able to add in some stationary biking, and he was advancing this very gradually to avoid provoking PEM. So in September, he could do 15 minutes twice a week. By October, he'd increased it very, very slowly to 20 minutes 3 times a week, and so on, so that in January he was doing 30 minutes 4 times a week. And I heard from his mother last week, and he's now been adding some walking and jogging, trying to get back to the kind of fitness he had when he could run 60 to 70 miles per week. The other 2 patients in this small series also had florid postural tachycardia syndrome on their standing test, one of them reaching a heart rate of 166 beats per minute. And their orthostatic intolerance was not due to inactivity. It began with the onset of their COVID symptoms. They all had mild COVID illnesses with no hospitalizations. They had some neurologic irritability that was impressive. One of them had hypermobile Ehlers-Danlos Syndrome. And all 3 had these allergic inflammatory manifestations. The boy I presented to you was patient 1. Patient 2 also had hives with citrus. The third one had a lot of dermatographism, meaning that you could run your finger along her arm and she'd get a big red welt. She had facial flushing with activity, and she had a family history where her father was on various drugs that would be effective for mast cell activation. 2 of them had histamine levels that were elevated. And this is something that Dr. Lawrence Afrin has been focusing on, that some of the post-COVID hyperinflammation that leads to bad lung disease may be driven by cytokines released by mast cells in patients with previously undiagnosed mast cell activation. And it may play a role in the development of long COVID as well. One of the things we have to be on the alert for is that people who don't know this field but see patients with prolonged symptoms after SARS-CoV-2 can make some mistakes. So this group from Ireland made the proper observation that fatigue following SARS-CoV-2 infection is common and independent of the severity of the initial infection. And they went on to say that a suite of interventions, included graded exercise and cognitive behavioral therapy, are needed to manage chronic fatigue syndrome and may be relevant to post-infectious fatigue. And by graded exercise, we mean this sort of rigid graded exercise. Everybody needs to gradually, at some point, increase their activity if they're going to go from completely disabled to healthy again. But it has to be the kind of activity that doesn't provoke PEM. We know that CBT is no longer recommended as the primary therapy of ME-CFS, although there is a lot of pushback from what I call the CBT theologians, who are unwilling to accept any of the evidence that's emerged in the last 25 or so years on orthostatic intolerance. If they did recognize that, they'd have to abandon their idea that CBT is somehow magically helpful for these conditions. POTS and orthostatic intolerance are among the most treatable conditions in ME-CFS and in long COVID as well. Let me also just point out that work from Franz Visser and Linda Van Kampen has shown that the brain blood flow in those with long COVID is even worse than that of those with 10 or 12 years of ME-CFS symptoms. So they get a 33% reduction in brain blood flow, and all of them meet ME-CFS criteria and have quite bad POTS in their long COVID population. So there's a lot of similarity. Many of us think that those who have a substantial impairment after COVID probably are going to meet ME-CFS criteria, and it may be that SARS-CoV-2 is yet another fairly common cause of ME-CFS. The hope is that with all the scientific minds trained on COVID and creative approaches coming from all of them, that there will be some information that is also quite valuable for our ability to better treat those with ME-CFS that began pre-pandemic. So I hope that is the silver lining in this awful couple of years of experience with this organism. I'm going to end there. I'll just show you a couple of places where you can get more information about joint hypermobility and Ehlers-Danlos Syndrome. The Ehlers-Danlos Society is an international group that does a lot of teaching. They have there's another group called EDS Awareness that has a number of very good webinar talks on various topics of importance. And the 2017 classification of EDS is published in the American Journal of Medical Genetics. I'll end just by acknowledging that we've had help from the Sunshine Natural Wellbeing Foundation for an endowed professorship. The Boyce family has been instrumental in keeping our clinic going for the last 20 years. We've had terrific research coordinators and nurses, as well as summer students, and many of the patients do fundraising to keep this clinic going. And you can see the Rose Research Runners Group, including Emily Steffensmeyer on the far right, standing with my physical therapy collaborator, Rick Violand, who's been another big contributor to the understanding of these diseases. I'm going to stop there, and there will be time for questions. So, Trudy, I saw a couple of questions in the chat that yes. I thought I could lead off with. One of them had to do with, how do you decide to call it EDS alone or EDS with ME-CFS? Where's the dividing line between the two? And I think this is a very good question that comes up frequently. Some people say, why add to the list? We know EDS has orthostatic intolerance and it overlaps with ME-CFS. I have taken the approach that I want to list everything that an individual patient actually meets criteria for, because we're at a point where we're just beginning to understand the connections among these. And I think if we accurately describe each condition that each patient qualifies for, we will better see the connections between the two. But I think we have to be concerned that the more labels that an individual has, the more they may feel sicker. I don't think most patients, though, are affected by that. I don't think there's a huge psychological component or burden knowing that you have both. Somebody else had asked, how do you take this to the next level biologically? And that will obviously need to come from people who have expertise in molecular biology. I had 2 points that I wanted to bring out there. One is that mast cell activation syndrome, which we talked about with some of the long COVID patients, is a condition where the mast cells release histamine and a variety of other biologically active mediators, including some that can break down proteins. And mast cell activation, for reasons that are a bit unclear, is much more common in the EDS and the hypermobility population. And so it may be that understanding the connection between joint laxity, joint hypermobility, and mast cell activation is going to be important, both for understanding which symptoms can be treated using the mast cell medications, like we did for our runner with antihistamines. And there's another paper I listed on the slide that long COVID can respond to antihistamine type treatments. But also recognizing all of the myriad features of mast cell activation can be important. Somebody had asked about environmental exposures and chronic fatigue syndrome. Some people reacting to strong odors and perfumes. And there's a lot of thinking that this could be a reaction to the mast, that the mast cells could be behind these responses to different chemicals. So that this intersection of EDS and mast cells and environmental exposures and ME-CFS is important to recognize. There's a recent paper, I don't know if you can see it, I'll hold it up, by a Dr. Sabiha, if I'm pronouncing it right, Malik, M-A-L-E-K, published a year ago. And she was wondering if the problem was not with collagens, but with the adhesion of other cells and other kind of molecular changes present in those with joint hypermobility, but that might be more important than just the stretchiness of the tissues. So I think people are starting to look into these questions with more intent from that. There's another question about the difficulty getting diagnosed in Norway. I think it's shared everywhere. One of the problems, if you have a condition that's got a 24% prevalence in high school students, namely joint hypermobility, is that if people want to get looked at, you need a massive number of clinicians to be able to evaluate them. People in the past have tended to want geneticists to get involved. Our group at Johns Hopkins has stopped seeing people for hypermobile EDS because they couldn't see any of their other genetics patients who had equal or more pressing needs for care. So I think to some extent we'll have to shift that activity of confirming the diagnosis to more generalist physicians and not ask the specialists to be inundated with these patients. The second part of that question was, well, what does it mean for treatment? And we think that there are a couple of things that make a difference. One is just recognizing the many other things that people with hypermobility can have. Like if you've got headaches, some of those headaches could be from a temporomandibular joint instability or dysfunction, which might require a mouth guard or muscle relaxants or dental work. Or if patients have some of the other things like a hiatal hernia or spinal fluid leaks, it helps you recognize more rapidly what else might be going on for that patient. We think, anecdotally, we haven't done a formal study of this, but we think if the vessels are stretchy, and that's what predisposes you to the orthostatic intolerance symptoms, which then aggravate all of the ME-CFS symptoms, that the patients with hypermobile EDS do better if you begin them on vasoconstrictor medications for their orthostatic intolerance. It's not a universal benefit, but our hunch is that they are more helpful in this population than in some of our other patients. The other thing is to recognize that the connective tissues lead to a lot of sloppiness in the joints. In other words, they can move, they can be in the wrong position, the muscles can go into spasm. And I think for our EDS patients with ME-CFS, like all other EDS patients, they need to have a very good relationship with their physical therapists to help realign the joints, reduce the muscle spasm, reduce some of the inefficiencies in movement. And I often say to our young patients with EDS that they are like a powerful, expensive sports car, a Ferrari. Their body is a Ferrari. It needs a lot of tune-ups because things can get out of whack easily. So I think knowing that people have hypermobility and EDS really has some clinical importance to improve overall quality of life and to make sure you're not doing the wrong kind of physical therapy. Those were the ones I could see, Trudy, in the Q&A in the chat. I don't know if there are any in Norwegian.
There's another one in the Q&A. She's saying, thank you for this webinar. My 14-year-old daughter has EDS and POTS, but we still have not met a specialist that have knowledge of POTS, and they all say POTS is not dangerous, drink water. My question is, are there medications that are recommended for teenagers with POTS?
Yeah, I think you can get that kind of nihilistic view from some physicians that they think all you need is extra fluids and salt, and that's just woefully inadequate for the vast majority of people with POTS, especially if they have real impairment in their activity levels. Many people with POTS, similar to the question we had about EDS versus ME-CFS, many patients with POTS also meet the criteria for ME-CFS. And they have enough impairment that one should be trying them on medications. We saw a girl from another institution who had had 4 years of POTS and fatigue and had not been tried on a single medication. We try a variety of medications for these patients, and it's better outlined in the webinar we did on orthostatic intolerance earlier that Trudy has, I think, on file. But things like drugs that can expand blood volume, like fludrocortisone, drugs that help with vessel constriction, like midodrine and the stimulant medications, and then drugs that can control heart rate acceleration, like primarily the beta blocker drugs, but also things like ivabradine, mestinon, and others. And so we have a very long list of medicines that one needs to consider in patients with POTS. And I think it's quite unfair to ask them just to tolerate, just to get along just with salt and fluids. For those who aren't really tolerant of medication, there are compression garments that people can use that help move the blood up to the heart and brain. But the vast majority of the children I've seen with POTS over the last 25 years really need some medication support to improve their circulation. In the orthostatic intolerance talk, I think I gave the example of one of our patients who's an occupational therapist who had a resting heart rate of 110. She had mast cell activation, and when she would exercise, her heart rate would rise immediately to 180 and trigger a 2-day migraine. So she really couldn't exercise. We tried almost everything else on her. Then we tried her on ivabradine or Corlinor in the US. I'm not sure if it's the same name in Norway, but that's a newer drug to control heart rate. And when we found the right dose, her resting heart rate came down from about 110 to 70 or thereabouts, and she could exercise for 45 minutes on the elliptical without provoking a migraine. So she needed to have her circulation controlled before she could tolerate activity. So I think it would be unfair to ask somebody who's fairly impaired with POTS to dig themselves out of that trench on their own.
There's another question about sleep. And do you know what connection there is to long-term sleep problems? Any advice on improving sleep when the reason for sleep disturbance is adrenaline, histamine, and other hormonal spikes during the night?
Yeah, so one of the things that is really a challenge is when sleep is very disrupted and the whole diurnal sleep duration is flipped. And so people are sleeping during the day and awake at night, and that increases social isolation. We try a variety of things for sleep ranging from mindfulness-based web or telephone apps, relaxation apps, melatonin, antihistamines. One of the interesting approaches is to give a short-acting beta blocker like propranolol at night in case the resting heart rate is high enough that it goes up enough to alert people and awaken them. Sometimes dampening down the heart rate at night can help people have more restful sleep.
And see, there's a question here. Do you accept patients from Norway at all at your clinic?
We're pretty backed up in our ability to even see the local patients. We get about 50 requests for consultation per week. And I can maybe fit in one new patient every week or two, given the number of people. We just have myself and a nurse in our clinic. But I would recommend the people that are much closer to you, my colleagues in the Netherlands, Frans Visser and Linda van Kampen have a very good specialty clinic. They use the same kind of approaches that I do and have had some very good successes. And I think they are starting to see some of the younger patients. So you might want to try them first.
There are a couple of new questions in the Q&A.
So one is on anxiety.
Yes.
There is, and I can, for Scott, I can send Trudy the Malik paper just so that she has that to post on the website. I'll send along some of the other papers on the overlap of joint hypermobility and ME-CFS. Jessica Eccles is a psychiatrist in England who's doing a lot of work on this overlap. One of the things to keep in mind is that when you have orthostatic intolerance, one of the things that the body does to respond to that is it pours out lots of catecholamines, epinephrine and norepinephrine, as we use the terms in the US, adrenaline and noradrenaline in Europe. And noradrenaline and adrenaline by themselves, if infused into a patient, can cause them to be anxious. So some of the anxiety that people feel with orthostatic intolerance is because of the high levels of catecholamines. And there have been papers written about people with mitral valve prolapse in the past who had been admitted to psychiatric hospitals for their anxiety. Somebody finally heard the murmur of mitral valve prolapse, put them on a beta blocker, the catecholamine levels came down, and the anxiety was completely treated. So it's really important to keep that in mind. We've also had free-floating anxiety in some of our patients that had either a cervical spinal stenosis, where they had narrowing of the spinal canal with a disc bulging and pressing on the cervical spine. And those patients had untreatable anxiety until we fixed their spine problems surgically. And then there was a marked improvement in the anxiety. So it makes sense that if you've got a disc pressing on your spinal cord in the neck, that you ought to have some kind of alert and warning sign that is going to the anxiety centers in the brain. So I think we have to have a more expansive view of the biology of anxiety too, especially in the settings where you can have loose ligaments at the skull base and all sorts of orthostatic intolerance.
When do you need to worry about hypermobility? As you say, sometimes it's an asset in dancing or some other sports, and sometimes it can later cause pain and perhaps even disability. When should you be worried?
I think it really has to depend on what the child is reporting and whether their activities are being limited in any way. You know, so I think as long as they're thriving, getting to school and able to engage in their activities and aren't complaining, hypermobility is just a trait for them. But I think we have to take it seriously when they get a lot of aches and pains in their muscles and joints, which can be very common in the setting of hypermobility, or any of the other more impressive features that we see with ME-CFS. Because there are things to be done. And my sense is that if we can treat them early, we can preserve their function before they have a much more inactive process. We've seen in people with hypermobility and EDS that if they get a sprain of let's say an ankle, and they have to be inactive for 2 weeks, when they've been habitually quite active, they seem to have a much more rapid decline in their overall function. So I think getting to treat people early is going to be really important. And that probably requires more people treating these problems than we all currently have.
Yes.
One person asked about raising the height of the pillow, and in the orthostatic intolerance talk, I may have mentioned raising the whole bed frame up 10 to 15 degrees. That helps people hang on to more blood volume and not produce as much urine at night. And some of the patients tolerate it and feel a bit better when they position the bed that way. You can't just elevate the pillows, you have to elevate the whole frame of the bed by 10 to 15 degrees. And again, not everybody tolerates that, but it's a fairly simple non-pharmacologic treatment that can help the orthostatic piece. Skip the ones on the biology of collagen that Ola had asked, because I'm not really that good of a physiologist, but I think all of the things in Ola's comment earlier about the connection of collagen and different hormones and other things, that's probably an important area for further exploration.
Someone recommends cold showers. Is that...
I recommend that for Donald Trump. I think he should have ice cold showers all the time. But some people find that they get very, very intolerant of the heat in the shower, and they have to sit down in the shower or lie down afterwards. Some patients find that if they alternate between hot, which might help their muscles, and cold, they can maintain their circulation better. It's really something to tell people to experiment with and see what works for them.
I think we're through. All I can say then is thank you so much for taking the time. And this webinar has been recorded and it will be submitted on our website, on YouTube and on Facebook eventually, when I get around to editing it. The previous webinars we've had with Peter Rowe are all on our website, and with lots of other resources that he has very kindly given us. So you can find them there. So always have to say thank you ever so much. I appreciate it very much, and I'm sure everyone else who's been listening to this does as well.
Thank you.
I also know that even if there may not be that many actually watching today, that there will be several thousand watching it later. So this is a great way of reaching people. So thank you so much.
My pleasure. All right. Take care, everybody.